Hello, and welcome to the Health GoLIVE Webinar series. Today's episode is brought to you by your friends at Grail. We would like to remind you that the Q&A feature is available, so feel free to send in your questions for our speakers throughout the discussion. And with that, I will turn it over to our moderator who joins us from Andreessen Horowitz, Vanita Argwala.
Hi, everyone. Thank you so much for joining, and it's a pleasure to be moderating this exciting panel of health system leaders as we talk about some of the challenges and opportunities in multi-cancer early detection testing. For those of you who registered, you saw kind of this futuristic iconography that was created for this event, and I actually quite like that. It sort of gives us this exciting future possibility of the ability to peer into patients' bodies and find something earlier. Every clinician knows, every innovator in the space knows that we all want to find cancer earlier if we possibly could, and that we would save a lot of lives if we could do that scalably, effectively, and accurately. But it's hard. There are a lot of challenges in how you implement this and how you do it safely. I'm a cancer survivorship physician myself, practice at Stanford, and really excited for you all to hear the perspectives of the leaders we've assembled today. I'm going to have this group introduce themselves, and so I'll just go around the horn here, and you'll get to hear just the very unique positions these folks are in as they think about how to design effective implementation for early cancer detection. And so I'll start with Dr. Patrick Mcgill. Welcome.
Thank you. Good afternoon. Patrick Mcgill, I serve as the Chief Transformation Officer at Community Health Network in Indianapolis, Indiana. I have a broad range of responsibilities from IT and analytics and a lot of things in population health. I'm a primary care physician, and so, excited about, how we can roll out the Gallery test to all of our patients, for early detection of cancer and screening.
Thank you. Dr. Adam Buchanan.
Hi, great to be here. Adam Buchanan, I'm the Associate Professor and Chair of our Department of Genomic Health here at Geisinger. Geisinger is a large community health system with integrated plan that's part of the central Pennsylvania center of the state for a fairly large geographically distributed area. And my training is in genetic counseling with expertise in cancer genetics, and we were the initial site for the first prospective interventional trial of a multi-cancer early detection test that was published a couple of years ago. So that's given us the opportunity to continue to talk about it and explore new ways to find cancer early.
And last but not least, Dr. Ora Gordon.
I'm Ora Gordon, Dr. Ora Gordon. I am a medical geneticist and an internist. I run a hereditary cancer prevention program for Providence Health System in Southern California, and I am the clinical director for our population genomics program for the whole health system. Providence is a very large integrated delivery network spanning 7 states across the West, and so we, as an organization, we're very committed to early innovation and really commitment to early detection. So I am the principal investigator for a 5,000 person study looking at the real world evidence and specific populations for high risk for the GRAIL test and how that affects our outcomes for our patient population.
Fantastic. So this is just an amazing group, folks leading pop health and pop genomics and transformation initiatives at diverse centers, Providence, Geisinger, and Community Health Network. And so as you're listening, keep in mind that you're getting this just kind of eclectic, beautiful combination of perspectives from a lot of different practice settings. So let's dive right in. The first question that I want to ask you all, and folks in the audience, we'll spend about half the webinar going through questions that we think will be of high interest to everyone who's joined here, and then we'll open up to questions for the back half. But let's start with just comparing a multi-cancer early detection test like Gallery to other, to the standard of care in cancer screening, and which is typically single cancer detection. We're looking at, programs like lung cancer CT and mammography and, the kind of current pillars of cancer screening, and how do you see the role of multi-cancer early detection versus these existing single cancer screening approaches, and how are you integrating both in your settings? I'll leave it at that, and whoever wants to dive in first.
I'm happy to take that on first, at least from our experience. So, I think there's some important statistics that we all have to keep in mind, especially as we start to look at new technology from an early detection, from screening and early detection, that, almost 70% of cancers that are in the US are in cancers that are outside of our 5 kind of standard screening. And that really makes you shape thinking about, what are we doing from an effective population health standpoint, and how do we better access individuals who are at risk in finding cancer? So that was a very important driver. I, of course, work in a hereditary risk assessment program, ranging from single high risks like breast cancer to people who have BRCA mutations and Lynch syndrome and have at risk at the same time for multiple cancers. So really trying to find a way to assess risk in a more comprehensive way. The flip of that for our general population, for our general, organization and health system, is that we know that there is very big variability in adherence even to our regular screening guidelines, and that our more vulnerable populations often are the ones who are not getting their mammograms or their colonoscopy even as recommended. And so part of the initiative that I am leading is dividing between these known high-risk patients and a primary care population to say, okay, looking particularly, because we have the ability through our kind of integrated network, those who are failing to meet their standard surveillance, who are not part of the kind of meeting their Healthy Planet guidelines, can we engage them in a way where this is something that will help them step in and lean into their own prevention and care and screening? So this is one of the reasons why it was a real draw to try to get that kind of outcome data that we need.
Super interesting. So 2 different populations, potentially sort of different drivers for why you'd like to deploy high risk hereditary cancers, prior history of personal cancer, but then also in the primary care setting, essentially improving access to cancer screening more generally. Adam, you were about to chime in.
Yes, we're also excited about what we can learn here. So for those standard of care screening tests, we've got decades of information about positive predictive value, number needed to screen, sensitivity, specificity. And I think that's the reason that most individuals in this space are thinking about multi-cancer early detection as complementary to those existing standard of care tests. So now we have all those things to learn about a test that can pick up multiple cancers, which have different follow-up, different diagnostic follow-up, and so forth. So there's much we can learn from a test performance perspective, as well as some of the downstream activities. Once someone tests positive with a multi-cancer early detection test, what are the challenges, or what are the things that help ease those challenges for the diagnostic workup, especially when you think about vulnerable populations. So there's a ton to learn here that's going to impact how we take care of our patients in a way that should meet who they are.
And when you say integrate, and Patrick, feel free to answer this question, but both Ora and Adam mentioned, well, we're not talking about doing away with existing single cancer screening approaches that we know are effective at a population level, mammography, colonoscopy. What does integrate mean for a patient, as they think about their annual set of a battery of tests that they need to have done with their primary care physician? What does integration of the multi-cancer test and existing other testing mean?
Yeah, and I think the way we've approached it is similar to Ora and Adam. And we see this really as an augmentation of the current screening guidelines that patients are having done, or we're attempting to have them done. Completely echo the comments on there's a lot of disparities in patients actually getting the test, the screening test, the traditional historical screening test done. And so we see this as a way to augment, but it's not a replacement. And I think what it does is as I have conversations with patients about having the test done, they've had their other screening things done, or maybe they're getting those done. Now this is another tool in the toolbox that we can offer them especially if they're high risk. They have additional risk factors, whether it's family history or smoking or whatever other risk factors they might have. We can offer this as a test to augment those traditional screening tests, just to potentially pick up the additional cancers earlier, because there's no other test that's appropriate to screen for many of the cancers that the Gallery test is looking for.
Do any of you have a perspective on any conversations that you've had regarding economic effectiveness in this augmentative world, where where the cost of screening on the whole is going to go up if we are strictly adding a new test to the mix? Long-term health economic analyses or payer conversations that you've had?
I think most of the work in that space is in modeling so far, and it's using a purported benefit of shifting a stage of cancer diagnosis to an earlier stage and then modeling the cost of that stage shift. And I think the hope is that that shift will offset some of the costs from what is now a new screening test that is added with some regularity, although it's not yet clear how frequent to do the testing just yet.
We're getting lots of questions. I'm just scanning real quick to see if I can integrate some of these with our existing planned conversation. Let me ask you all a few more questions that I think will hit some of the questions that are coming in. There's a lot of interest in understanding, the patient experience with Gallery. How do you introduce the testing to patients? What exactly is the informed consent process, so that we understand as providers, that patients understand the risks and uncertainties associated with the knowledge provided by the Gallery test? How do you decide exactly what information to share and when with patients, and how are they reacting actually also to the early screening results? Can any of you share a little bit about that, the patient counseling associated with deploying a test like this?
So I'd be happy to speak to experience to date. So we have thus far accrued over 700 participants into what we call Gallery in Action part of our study, which is where we're offering the test to patients and engaging them in both long-term outcome, the reflection. So just for the audience to know that there is a national registry of real-world evidence, a national registry that is looking to accrue 35,000 patients across the U.S. We at Providence feel very committed to that evidence-based, really getting the evidence-based we need for efficacy, for the test performance itself, but really also for benefit to patients and for value-based care, to really try to get all of that together. When I talk to patients, and we have two arms actually, one where providers can just offer it as part of their own practice, and that is on a commercial basis, to which we're trying to engage our providers to still have patients be part of the reflection outcome registry, and part of our study where we are inviting patients to participate based on certain criteria. When I talk to patients, my high-risk patients, as you can imagine, are very highly motivated to have screening in any capacity that they can, particularly those who are at risk for cancers that are very challenging, like ovarian and pancreatic. So there has been a very high interest and uptake. It is fairly straightforward to explain the specificity and what may happen, as opposed when you get a positive signal, to walk through that there is the way the test is designed. Is this in time? Is there evidence there's cancer circulating in your body, and that this is kind of a phenomenon that we see all the time in all people, and that this test has the ability, differing from other multi-cancer early detection tests, to make a tissue prediction, and kind of what will happen in that, including the potential that the positive signal is unresolved. And it's very important, I think, to walk all the way through what is the likelihood of you testing positive, which is very small, and in kind of what we certainly the data that came out from Pathfinders, and it's great that this meeting is timed with the ESMO and the actual outcomes from the Pathfinder study, as well as what was kind of the earlier validation study. So between 1% and 2% testing positive, and then from that, maybe 1 in 2 or 1 in 3 won't immediately get a resolution. So that's how I open that conversation and help people think about that and frame it against also something like mammography. If you get a BI-RADS4 mammogram, you are then marching through a series of evaluations, repeat imaging, potential for biopsy, of which most don't end up being cancer. And then we follow you forward. And so that really helps, I think, patients frame how to think about this test versus what they may be more accustomed to. And it's very, very important to have patients realize that this is not a substitute at this time for routine screening. And it also is not there is no chance you have cancer right now.
Yeah, multiple questions have come in on, hey, I have let's say a high risk patient, high risk for breast cancer, maybe they're a BRCA patient, or I have a high risk lung cancer patient with a long history of smoking. If the test comes back negative, how do I know I haven't still missed an early cancer? I'll offer an initial response to those questions, and I'd love for the group to chime in, but you don't, right? I mean, but you don't with our current screening regimes either. And so I think one way to look at this is, that you've increased your NPV relative to the standard, and all the panelists are saying you don't remove the standard. So if you're a high-risk breast cancer patient who per guidelines should be having alternating mammography and MRI, I'm assuming, Dr. Gordon, you're saying you would still do that, but offer an extra layer of screening, which is not perfect, but additive. And I think the same would be true in the high-risk lung cancer setting, which someone
yeah, that's exactly right. I mean, our current tests, you have people that have negative tests and come back 3 months later, 6 months later with a cancer, and I would echo everything that Dr. Gordon said. We follow the same process with conversations in the clinic with the patient, explaining the test, explaining if it comes back positive, this is what and we don't go into a lot of detail until it comes back positive, but this is what the process would be. This is what it would look like. We've screened just over 600 patients so far since April, and the uptake has been very, very positive. And it's really more. I think a lot of the questions from the patients really stem around the cost of the test. What are the other impacts if it's positive? Is it going to impact other things? Insurance and those types of questions, which I think are still kind of unknown broadly, but those are the types of questions that patients. I can tell you, the patients that I've screened, I haven't had anybody say no, because they all, to the earlier comment, they're all excited that, hey, this is an additional tool to help reduce my risk or help find these cancers earlier.
Okay, so that sounds great. And I think there's some skepticism, though, in the audience that, of course, that sounds good, but what if what if my patient can't afford the test? What if you've just kind of had that conversation that that Dr. Mcgill and Dr. Gordon you've described, but then who's going to bear the cost of gathering that additional valuable information? Can you all weigh in a little bit on today? What's happening on that front? What is the patient experiencing as an out-of-pocket cost? If you've had insight into that, what is the health system experiencing? What's being covered?
I'll give you I have the easiest answer probably, and then I'll hear from the other two. We took the approach that we went to our network foundation, and said, if we'd like to get this project off the ground, we know that cost is going to be a barrier. Would you help fund the cost of the test? And they said, absolutely. We'll fund X number of tests. And so it's allowed us to get the project off the ground and taking cost off the table, right? There really is no cost conversation about the test. Now, certainly if it comes back positive, then the additional workup, that's where the conversation on cost comes in. But we wanted to focus on getting the test implemented, integrated, and not have the financial barrier that we would experience if we're trying to negotiate payers and other contracts like that.
So our experiences with a different multi-cancer early detection test, but I think a lot of similarities about both how we talk about it and our experience about cost as well. The research study that we were involved in covered the cost of the test itself, but did not cover the follow-up diagnostic workup or any cancer treatment in those who were diagnosed with cancer. We didn't hear any concerns about those costs in those individuals. One of the things we worried about early was whether the abnormal research-based multi-cancer early detection test would be accepted by insurance companies for performing that diagnostic workup and beginning treatment, and no concerns there with that being sufficient evidence for moving on to the regular workup that you have. The other thing that's a distinction here that was touched on earlier is how you have a signal about where that tumor might be. So the tissue of origin. And so one approach is to bake that into the test itself. Another is to add another imaging tool like a PET-CT, which has been our experience. And also introduces some of those same concerns about incidental findings and so forth. But again, we had not heard about any sort of financial toxicity, as it were, for the follow-up there.
And so you are, in your current practice setting, recommending a PET-CT as follow-up for a positive test?
Yes, and that's because, so we haven't been involved with the gallery work, but we've been working with Exact Sciences and a test that grew out of collaboration at Johns Hopkins lab. And so that test doesn't have the same tissue of origin localization that the gallery test does. And so the test can be conceived of as blood test plus imaging. Okay.
And Dr. Mcgill, Dr. Gordon, are you all following up with the PET-CT, or are you using the tumor of origin information provided by the gallery test instead of a PET-CT and trying to do a targeted tissue organ-specific screening?
Organ specific. And so I also just want to talk about, so Providence is a system because was the first health system to sort of engage as an integrated system. There are two channels, like I had said. So there's our 5,000 person study to which we fund the test, and then the commercial for anybody who wants access, and the health system is offering that test at gets a reduced price for Providence providers and patients to get access to it as a self-pay. The follow-up is of course of great importance, both from a patient standpoint and for a health system that has its own health plan but is not fully closed. It's not a fully closed system. So we have a few things. One is that we have devised an early detection cancer case conference, having any provider, whether it's part of the study or just offering it on their own, to be able to bring a positive case forward. And we're encouraging everybody to do that so that there can be a consensus about kind of next, what the workup should be. As a commitment to the mission of Providence that to protect vulnerable patients, there is actually a fund that has been established in case, as part of the study participation, that somebody got a denied cost of test for their workup. So far, no one has had an issue with a denial for workup, just like Patrick and Adam have said that sometimes it requires a peer-to-peer, or there's some conversations that need to happen, but that has not been an issue. I have only one example where someone did not have diagnostic resolution on what would have been the expected tissue of origin. I have two cases, and we can get into some case examples a little bit later on, but we have a very integrated onboarding process for our providers in terms of the education before they start offering the gallery test, have channels to which we have a lot of supportive information, kind of a phone a friend. There's a genomics manager who kind of oversees testing for the primary care providers who are offering it, as well as the study patients. So we're really trying to be very cohesive in the approach, both in terms of offering and the workup of the patients.
That's great. I'm envious of the infrastructure you just described. I need to phone a friend more.
Yeah, and we have a similar approach. If we have a positive signal, we refer them not to a tumor board per se, but we have a high-risk clinic, high-risk cancer clinic that we refer to. And then they take the work up from there, working closely with the oncology providers and team, really on a more focused tissue approach.
So if I could summarize all the perspectives we've heard so far, there were a lot of questions on cost and follow-up and patient experience with all of that. The upfront test is not yet widely reimbursed. And so our panelists are telling us they've devised creative strategies to seek funding to support the rollout on a population-wide basis or for a specific subpopulation to support the cost of the upfront testing. In other cases, they've offered direct patient opportunities to opt in to the testing at reduced cost to patients. But the good news so far is that there has not been any resistance observed from payers on the follow-up, which was a big open question at the time of the initial commercial launch. And so at least that's reassuring as a starting point. And clearly there's more to do and more data to justify coverage for the upfront test. But that's reassuring to hear on the downstream follow-up. And the downstream follow-up, you all have said, is different depending on each system's experiences so far. Adam, you mentioned at Geisinger PET-CT. Aura and Patrick, you've devised systems that are tissue-specific, using the tissue-specific information reported back in the test. Thank you. There's a really great question in the Q&A, actually from an old friend of mine, Sana. Good to see you, Sana, who is commenting on, hey, what is ultimately the plan to get Gallery in front of the USPTF to really change primary care guidelines in a wholesale way? And she notes that historically, the organization has waited for long RCTs with survival endpoints when approving novel cancer screening regimes, but that may not make sense in the context of a rapidly evolving genetic technology. And so have any of you had any interactions with regulators, assessors, guideline bodies in the primary care world who you think may be interested in alternate real-world and surrogate endpoints of utility?
Well, I sit on the steering committee for the Reflection Real-World Evidence Study, and so that is definitely a evidence to Medicare, the very well structured for both FDA and Medicare recognition of outcome endpoints to recognize the Gallery test. So that is part of that goal. The SOAR study, which is the MCED test for the exact sciences, to the same thing. That is a very structured in terms of what those endpoints are to be able to provide the evidence for recognition and integration as a part of a standard of testing. And the longer term, decisions about frequency of testing, for example, the general current kind of think there is no strict guideline, of course, is about on an annual basis the way you would do sort of an annual assessment of for general health screening and for those entering eligibility. The internal Providence Health Plan initially said, we're not going to recognize the kind of standard answer of we're not going to recognize this. This is going to be an experimental test, but is very, very committed to sort of seeing that value-based data, and that's part of why we wanted to participate internally as part of the bigger evidence. The other thing is that it's important for, I think, the audience to know that there's a very large study going on in the UK through the NHS, looking at the Gallery test again, concomitant with serial mammography, to again really start to get more very rapid accrual of data for comparison of single imaging test against an MCED test. And so there's a lot that will be coming, hopefully, in an accelerated way.
A lot more data. Great. Mm-hmm. Although it might make the pop health leaders cringe, I'm going to take us to the extremes of the population and just kind of ask you all to share, even if anecdotal, which again, we all know anecdotes do not drive pop health decisions, but sometimes they give us intuition, inspiration, or help us see the risks of an approach. And so I want us to just, for a moment, leave the principles of pop health and think about these extremes. Can any of you share just some really inspiring, examples of how this has really helped in your patient populations, where you've really been able to find an early cancer? There's interest in the Q&A on, have early stage cancers really been detected this way? And then on the other end of the spectrum, there's also interest in the Q&A on, of course, the incidentaloma and the risk that patients who have false positive tests, the risk that they undergo costly, potentially invasive workups. And have any of you had experiences kind of on that as well? And so I pull yourself to the extremes, if you will, and I'd love to hear some both positive and challenging stories.
I can lead with a positive. So, one of the great hopes of this type of technology is that it'll detect cancers for which there's not standard of care screening, and that are, often detected at late stage with poor prognosis. So we had a participant in the study who was found to have an early stage ovarian cancer that was quite large, but also localized. And she went on to surgical treatment, chemotherapy, and this was now 4 years ago or so. So and continues to do well and continues to check in with us. And
she was asymptomatic at the time of the testing?
Asymptomatic, yep. And so, we have some of those kind of hallmark cases that we had hoped we'd find, and there are a few of them. On the flip side, we've been carefully tracking on the incidentaloma front how much you have to do to work something up and how invasive it is. And so, is it that you can stop without doing anything invasive, or that you have to go on and do, kind of a lung biopsy, or open abdominal surgery or something like that? That's only happened single digits in the more than 10,000 participants in the study that we had. So it's rare, but I think it's important to track it and to try to think about degrees of invasiveness for that workup.
And I can, I'm happy to sort of share.
Either side, yeah, please.
So two different kinds of examples. And so, we now have about 1,000 patients who have been sort of through the commercial arm, and then 700 who have been through this enriched high risk arm, both survivorship and upfront higher risk for family history of hereditary. So I have one patient who had a 40-pack year smoking history, but was just very reluctant to was eligible for a low dose CT screening, did not want to do it. And then was offered the Gallery test as a mechanism of sort of engaging the, let's just see, and came back with 2 positive signals, one for lung and one for renal, questioning renal or neuroendocrine. And
why were they resistant to the low dose lung CT, if you don't mind?
Just in a I'm not really that worried. I don't really want to do it. I don't want the radiation, that sort of this sort of standard resistance. And then once they had a positive signal on the Gallery test, then went through imaging and had a stage 1 lung cancer and actually a stage 1 renal cancer, and were completely asymptomatic to both. So that really is sort of the greatest tale, if indeed, that is something that we can see at scale to really make a difference in terms of early stage detection. And again, it just happened to have seen all of the data coming from the Pathfinder findings from the ESMO presentation. And so there's some really good numbers that for the audience, there's really good data there now to show the stage 1 and stage 2s and in what tumor types that was indeed found within that 6,500 patient Pathfinder study. And then the other example, which is that I'm still, kind of thinking about what is the impact, and certainly a very different kind of story. I have a patient who's a stage 1A breast survivor. And in our protocol, we have 5-year survivorship. That 3 years has been sort of a benchmark for both Pathfinder and also for the SOAR study, I think is 5. But if you came from a hereditary risk, then I said 1 year, because that risk for a second primary. So this patient was eligible at about 18 months after her stage 1 breast cancer. She had a negative mammogram and had an ER positive tumor but had failed tamoxifen, and so was not taking any adjuvant therapy. Her signal came back as breast. She had a negative mammogram. She had an MRI, which was negative. So her breast surgeon said, you know what, it's fine. You're good. You don't need to do anything else. The test was probably just a false positive, and I'll see you back in 6 months. But because she was part of our study and I engaged with the medical oncologist who she was not seeing, and said, I think this patient needs further workup. I am concerned that this could be evidence of a distant recurrence. As an aside, she had been complaining about hip pain and had, seen her primary and was just, getting some arthritic and PT and local. Turns out that she had a PET CT, and she had widely metastatic bone disease, and was at risk for a pathologic fracture, but had not had one. That hip was pretty involved. And so she was.
But the breast MRI was negative?
The breast MRI was negative. And she had a 1A, a small 1A, 18 months ago. So it is a very different kind of story.
Yeah, this is a head scratcher. Yeah, interesting. Thank you for sharing that.
Sure.
Yeah, thank you for sharing that. That's thought-provoking. There are questions in the audience, though, that, well, what if these are kind of the minority of cases, and what do we do about this majority of patients who, even if they have a positive test, may not have any actionable finding on further follow-up imaging, and that is still the majority story downstream of even a positive test, just given the very rare incidence rate of cancers in an all-comer population. And so how are you all rationalizing that majority experience, even among patients who have a positive test? Clearly, there's a lot of momentum and energy and gratification for the providers, even if you find a few of these very early detection, early cancers that would otherwise have created challenges for patients. From the patient perspective, though, when you have a positive on the screening and then a negative on the follow-up, that can be vexing. And how are you all thinking about that?
Yeah, so we, we're much earlier in our journey comparatively. We've like I said, we've done about 600 tests, had about 6 positives. One was a similar story to Aura's patient who known breast cancer and then came back with a positive breast signal. So, but it was a recent breast cancer diagnosis. So, there's a question about whether should she have even had the test done. Those types of conversations. But I agree with you. I think but it's very similar with other screening tests as well, right? When you get a positive lung nodule, or that you need a follow-up, or an abnormal mammogram, you're going to have shorter intervals. And that's really why we took the approach to engage these people with the high-risk clinic. It's a higher touch, more comprehensive, there's defined protocols really tied into oncology. So if it's a positive signal and a negative workup, it does create that additional level of engagement and follow-up to say, okay, we want to make sure that you are getting your appropriate your other screenings done at the same time. We're going to stay in closer contact with you. And I do think that it can be vexing for people. And then, they start to think, well, the test was positive, workup was negative, this was something missed, or, those types of things. But I think it's all part of the journey and the process that we need to work through. It's all part of that kind of open communication and helping patients understand, what to expect and what might occur. And I think it really, it goes back to just with everything we do, that level of engagement and communication, I think is key.
We've been curious about the same question about reactions to a false positive. We've done some qualitative work and have interviewed a couple dozen women who had a false positive and wanted to understand their experiences better. And as you can imagine, we were worried about anxiety, worried about the lingering concern about an occult cancer. We didn't hear a lot of that, which was, I think, reassuring. We heard a little bit more relief in those individuals that the workup was negative. It's not the positive result was not anything anybody described as good news, but it was manageable news. And so that I think is something that most of the women we talked to were putting it in their frame of reference for screening tests overall, that sometimes it's going to be positive, but then things are going to be okay. And that's how the conception of it seemed to be in this particular case.
Helpful.
And I think that, it's important, again, also just to sort of reframe. So one is that it's not the majority of positive signals that don't have diagnostic resolution. It's the positive predictive value is about 40%, and it's higher in those who have a higher a priori risk for cancer. So I think coming to your population, is this once you turn 21, everybody should start having a Gallery test once a year? I definitely don't think we're at a place where that's going to be the offering that we really need to be thinking about those who have an elevated risk, whether that's age related or whether that's exposure related or whether that's family history and germline related. And at least certainly for now. And that what we don't know in those false positives is this a lead time? Is this actually a cancer that's not yet imaging detected and not yet in our ability to detect it, to which we want that continued engagement, where you really, when you're offering this test, and you need to be able to, I think, feel assured that that patient will be part of your own continuity or your system's continuity, and that can follow forward. And those are important things to see over the natural history of the test in that person's health. Unlike, I think, when you think about cervical screening and mammogram screening, I mean, the positive predictive values in the single digits, and we just sort of accept that. Like, we just go, okay, yeah, but that's what we do for everybody. So I think some of it is this, kind of hyper focus because it's so novel and because it's different, but we have to keep coming back to sort of what is our current standard of guidelines and what is our current standard of acceptance.
Yeah, this has been described as exceptionalism or genetic exceptionalism in the initial rollout of genetic testing in some cases for rare disease or even tumor sequencing. And it's true, it's a difficult challenge because we all want the numbers on sensitivity and specificity in a screening context or any other diagnostic context to be as good as possible, as close to that beautiful curve that we're looking for, but it is important to remember that our current standard of care is imperfect as well, and we have to view this as augmenting what we have, and then think through the challenging questions that audience members have posed on how to support the cost of that augmented screening. But that's a great point, or on caution around exceptionalism and exceptional standards for new tests.
Well, one other thing to add, I think we talked about what happens when you have a positive signal and a negative workup. I think that you need to have just as many conversations around a negative signal to continue your workup if you're high risk. I mean, to continue your screenings and other things. So you could fight the balance of, I had a negative Gallery test, I'm good and I'm clear. I don't need to do all this other stuff. And I think that's part of that conversation. So it does go both ways. Positive signal, negative workup, negative signal, you got to continue your workup.
And that's certainly part of our study, because that's one of those same questions. Is somebody going to say, well, I'm good, bye-bye, that's it. And so also in that counseling and language around kind of understanding that this test and this test in the context of what we have for our current standards.
And we didn't see a pre-post difference among those women who did test negative and their adherence to mammography. So that was encouraging.
Yeah.
If I recall correctly with the ESMO data on Gallery, there was some mention of the standard of care screening and any difference there for test results. And it was similarly encouraging, but it's a key metric to look at.
As well as anxiety and, anxiety around novel testing, anxiety around a positive result, and kind of, and we see the same thing in, sort of germline testing, the anticipatory anxiety. And then once you're sort of in the pipeline, that anxiety goes down regardless of how that turns out.
I'm gonna pick a provocative question in the answer group, just because I know that it's colloquially often invoked as folks who are trying to understand how this test compares to other screening tests, and that is the comparison to PSA, kind of this notoriously complicated, controversial test where we've landed on a clinical guideline that involves a lot of patient preference and conversation, and it's just hard, right? It's hard. There's a test that has some diagnostic utility, but not enough for screening bodies to consider it to be a standard recommended cancer screening test. And so the question is, how do you compare and contrast in some ways this test with a test like the PSA test, which, and both carry a certain risk of false positives that are difficult to think through. Have any of you kind of engaged on that specific comparison or have a perspective?
I think some of the PSA challenges are ones that are yet to be answered here as well. So, PSAs haven't done a very good job of distinguishing between indolent and aggressive disease. And it's not always clear that the cancers that you detect with the multi-cancer early detection test are going to be aggressive necessarily. And that you might just be experiencing lead time bias if you're seeing any survival difference there. So we still need those longitudinal data to understand those impacts there, and ultimately the impact on mortality. I saw other questions about how long this is all going to take, and it's going to take a while. But there's certainly, with the real world evidence approaches, maybe ways to shortcut some of that. But I think some of the challenges are really well recognized, and so that helps us frame what data we collect and how those are reported.
Yeah, that's. Thank you for flagging this point, and many are concerned about kind of the notion of an indolent cancer that we never needed to find anyway, and that is true in some cancer types, not true in other cancer types, and so that's kind of one important thing to remember with PSA versus some of the other cancer types that are being detected on this test, and so that's something that we're going to learn a lot about, and every early stage cancer that was detected in Pathfinder, there'll be more follow-up data coming on how those patients were managed, and a clearer perspective on whether those cancers indeed needed to be dealt with at that stage. So I think that's a great point and a topic on which we'll collect more data.
And I think that, just in terms of the biology of cell-free DNA and kind of recognizing the difference, is that the tumor has to shed into significant quantities to meet that threshold. And so there are some solid tumors that based on aggressivity have that volume of dumping of cell-free DNA. There's some that are really related, that like with prostate cancer, for example, that you have to have an aggressive, or it seems to be that indolent cancers are not detected, indolent breast cancers are not detected. So again, that's both speaks to why you need to have continued screening, because mammography for a DCIS, for example, is not going to be something that's probably going to be picked up by a Gallery test. Whether or not we need to use other analytes, for example, for GU cancers, whether it be urine and the same kind of thing. And then there's some tumors that just don't tend to dump cell-free DNA like endometrial and thyroid. So I think you really do want to have a good understanding of sort of the mechanism of action of the test, and as opposed to sort of an image-based, sort of, which is sort of flat. And so I think that that's an important distinction, and we'll see over time. So early stage would suggest, at least to literature to date, that it's early stage, which would be an aggressive cancer, as opposed to an early stage indolent that is not, that would be over,
Right.
that would be
Less
overtreated.
likely to be flagged. Yep.
Right.
Great. I think we only have a few minutes left, and I'd like to take us, back to the pop health discussion that we started with at the beginning. And we've had a lot of interesting discussion on patient anecdotes, on some of the complicated edge cases in a way. So let's come back to that kind of center. And many of all of you in your leadership roles are very focused on creating health equity at a population health level, and there's a lot of interest in our audience members today in, fundamentally, how can they tie this new regime of cancer screening to a pillar of population health that we all believe in deeply, which is health equity. How do we make sure that that every patient is receiving equitable care and an equitable opportunity to manage cancer detection and cancer treatment as early as possible? Can you all, I just love to go around the horn here and for you all to share your perspectives on the role of early cancer screening in this way, the role of that in promoting health equity.
Yeah, so I'll start. I mean, I think I actually, from my perspective, and I lead a lot of our health equity social determinant programs, I actually think this is a way to actually improve on the health equities, right? And there's a lot of barriers to get just the traditional screening test done, transportation and scheduling and those types of things, just to go to have a mammogram done, go to have a colonoscopy, taking off work and the time and finances, required. So, I think that this is a way to start. This is not this magic bullet. So please don't take what I'm saying in that, but I do see it starting to level that playing field somewhat. It's at least a step in the right direction. Now we have to address the cost. And, I think that's where, that, as we mentioned earlier, that has a potential at this point to create a further divide. So we have to be mindful and address the cost if we're gonna leverage this to address some health equity issues. I mean, we know that the differences in screening, between different populations, adherence to the screening guidelines. So, I think that this has to be a way. We have to go in eyes wide open and use this as a way to start to bring those together. But again, I think we can't overlook the cost. That the cost of the test, whether it's covered or not, will have the potential to create further health equity divides.
I completely agree with that, and the risk of exacerbating those disparities. We've got a large distributed rural medically underserved patient population, so we already have to work fairly hard in some context to reach patients for access and try to level that playing field as much as possible. So we're fortunate to be able to rely on some of those existing programs and opportunities to get as close as we can to patients, but I also think we'll need to be really clear about what additional dedicated outreach we'll want to have from a trust building standpoint and communication standpoint, so that we're, again, not exacerbating disparities with new technology.
And our programs, so there are two things. One is that, we are utilizing our centers for outcomes research and education, which is our social determinants of health kind of engine for equity and mitigation of disparities, as part of our development of this program across our health system, which is from Alaska through Texas, so has a lot of variability. And it is because it's not a closed health system. We have a lot of variation in payers and those who are on state supported. And so we're really trying to deliberately outreach to those who have been who are underrepresented or underscreened. And we are using some community mechanisms, novel ways to use community leverage to educate about cancer screening and to get a sense for whether a stool-based test like a Cologuard versus a blood test versus support to get in for routine screening, and which is more likely to get engagement, or where do we see those? So that is embedded into the work that we are doing. The Pathfinder 2 study, which is deliberately trying to accrue for more equity and really see that. But it does fundamentally come down to it. This is at cost it's a very expensive single blood test, to which there needs to be the mechanism for follow-up. You cannot have this test unless you can get the imaging and testing that you need after that, and the mechanism to do so. So again, kind of in our health system, we said that's why I wanted to be a Providence patient and provider, because we could shepherd that way. So there are a lot of things to be thinking about in that way. And we don't, and it'll be important to see, is it more acceptable for somebody to get a blood test than to, handle their stool, and is that a way to leverage those who are underscreened at this time? And so I think that it really is incumbent on anybody who is interested in being involved and as a provider and as a healthcare system to say, we have to be part of the data. Like, you can't just do this. And I think it is not responsible to just offer a novel test in a bubble. You have to be kind of contributing to the evidence to say what is this best for, or where are there limitations to which it won't be the best for kinds of patient populations. How do we mitigate issues of equity and take it that way? Back in the day, germline testing was $4,000 for 2 genes, and now it's $250 for over 100 genes. And so the dial moves as we get that data and that engagement, and that's certainly been across my and Adam's clinical careers. We have seen that transformation.
Super helpful perspective. I think that's an interesting analogy to think about, as cost and access to hereditary risk testing has changed over the years. Something similar could happen here. There are lots of, emerging early cancer detection regimes, as you all mentioned. This is not the only one, and so there's going to be a really interesting way in which to combine them clinically, but be eyes wide open about kind of which patient populations and settings and cancer types different tests are most useful for. With that, I thought we were up on the hour, but do we actually have another 15 minutes? Does someone know? Maybe we have another few minutes here. One maybe final. Okay, it looks like actually just scheduled until the hour. So sorry. Back to my original plan, which was to leave everybody on time and on schedule. Thank you all for joining us. This is a really, really interesting discussion. So grateful that you all were transparent and honest about what you see as opportunities and challenges. And thank you to the audience, really. We had a very, very engaged group, ask lots and lots of questions, many of which we got to cover. One last question that I will cover. Someone asked if this session will be recorded and emailed out. I'll leave it to the HLTH panel organizers to comment on that question, because I don't know. But for everyone who joined and asked questions, thank you. The answer is yes, actually. There will be something that will be available for you all to watch later, or watch if you missed parts of this. Thank you all again. Thank you, Dr. McGill, Buchanan, and Gordon. This was really fun. Appreciate all the learning.
Thanks for having us.
Thank you.
Great.
Thank you to Vanita and all of our speakers. Please visit our website at hlth.com to catch up on all Health GoLIVE webinars. And join us in Las Vegas, November 13th through 16th for Health 2022.